Um, Good afternoon. My name is Steven Aguilar Miranda. My topic is Case 7 and 2018. 73 years old woman with swelling of the right groin and fever. Fever. Continue. The case. A 33 years old Caucasian woman presented to the emerging department with a 6-day history of fever and right groin pain and slimming. Associated symptoms included itchiness, diarrhea, malaise, weakness, nausea, cough, and anorexia. Upon presentation, she admitted to a recent hail on a bubonic plague endemic train in Colorado. Her vital signs were unremarkable and the physical examination demonstrated normal findings except for tender, er, everything nose, noculum right inguinal, lymphadenopathy. The patient was admitted for intractable pain and fever and started on intravenous cefoxitin, 2 grams intravenosa every 8 hours and oral doxycycline 100 every 12 hours for pelvic inflammatory disease versus tick or flammable illness. Due to the painting recent treat to a place infected area or symposium for Yersinia pestis infection was high. The patient was including a negative pregnancy test and urinalysis, and complete blood count demonstrate a white blood cell count of 8.6 per 103 liters with a 3 plus less 3 6 and a platelet count of 1 1200 per 103. A complete, a complete metabolic panel showed hypokalemia and hyponatremia. Blood curves were negative for any bacterial or fungal growth after 48 hours. Stool cultures were negative for Salmonella, Shigella, Campylobacter, Campylobacter generally Yersinia, and Escherichia coli. Shown for Gardnerella vaginalis, Trichomonas vaginalis, Candida, Chlamydia, Trichomalis, and Neisseria gonorrhea also were negative. Like Berthollet, Sensley, and Eterpili antibodies were also negative. Francisella tularensis was not cultured due to the long suspicion. Imaging. Imaging includes a normal chest X-ray and a computed tomographic scan of the abdomen and pelvis that showed enlarged right inguinal lymph nodes with fatty staining, a thicker distal right ellipsoid, hepatosplenomegaly, and enlarging right axonema. A picture 2 internal intrusion of the bubble showed two enlarged breaks. Lymph nodes, the largest measure 3.5 for 1.4 and for 2% semester, and 8 enlarged inguinal nodes. Picture 3, the patient continued to have a long-growth fever, diarrhea, and inguinal lymphadenopathy throughout her first two hospitalization days. The cefoxitin was discontinued by day 3 and the consulting infectious disease physical started oral metronidazole 500 mg every 12 hours due to the patient's failure to improve. Later that night, the patient experienced increasing erythema and pain in the heart inguinal region. A repeat ultrasound showed increased inguinal lymphadenopathy with the largest node nursing 2.3 for 1.5 for 2.5 and 2.7 for 1.3 for 2 centimeter figure 3. Continue. The diagnostic although the internal grand state was negative for his hernia, clinical suspicion pointed to a diagnostic of bubonic plague. Serology was considered, however, it was not available through the hospital, and definitive diagnosis required bubble aspiration and culture, which was performed but required 48 hours before result with a delay. By 5, the patient was clinically prepared and the deemed safe for describe an empiric treatment with ciprofloxacin 7,600 ml twice daily and doxycycline 100 twice daily to complete a 14-day course of antibiotic therapy for bubonic plague. The bubonic is subsequently great hypothesis, confirming the diagnostic. The patient made a full recovery and was greatly improved when seen in the up-to-10 setting with the treating infectious disease physical. Up-to-10 ultrasound repeated 3 weeks after study showed borderline lymphadenopathy no greater than 1 centimeter. The treatment, food and drug administration and pro-treatment included streptomycin, dicloxycin, 200 perioral once daily for 10 to 14 days, and fluoroquinolones. Trimethyl sulfacetamide might be used as an alternative but limited, including potentially incomplete for isolated response. Thank you.